incredibly honoured to have a special guest speaker today, all the way from the USA, Dr. Mark Melin. And I'll just read out the short bio that Mark has provided. So he's a surgeon and medical director of the M Health Wound Healing Institute and an adjunct associate professor in the University of Minnesota Surgical Department. His interests and educational niches include management of lymphedema in the wounded patient, the endothelial glycocalyx, adjunctive micronutrient application to wound care, micronized purified flavonoid fractions, polygenic abnormality impact upon wound resolution, wound pH and biofilm management, and emerging technologies in wound products and wound technologies. He participates in the educational activities of the Surgical Department Resident Training Program. His additional interests include human physiology and adaptability in the weightlessness of space travel and its translation to improving patient care on terra firma and achieving nominal human functionality in extreme environments and extremes of healthcare. He resides in the suburbs of Minneapolis with his wife, Cindy. They have 4 grown children and 3 rescue dogs. His family enjoys the Boundary Water canoe area, hiking and reading. So thank you very much, Mark. Over to you. Oh, I think you're still muted, sorry.
So it's a big honor to be here. And I have to just say it was such providence to be able to run into Rowena. So we were given a talk down in Houston, all virtual, and she and I were in the same audience and connected that way. And she's just been phenomenal. I consider it a mentor and just great wisdom. So you all are most fortunate that you get to hang out with her. And I'm so looking forward to getting to Australia where I can hang out in person as well. So my whole journey started with wanting to be an astronaut, like I'm sure many of you have wanted to be. And I tried to get into the Air Force Academy. I got a senator's nomination, but I'm colorblind. So color blindness is almost an automatic out because hard to fly a jet if you're colorblind. And I wasn't smart enough to be an engineer and to get in the Air Force Academy. So ended up going a different route, ended up in medicine. And then we're going to talk about an event where an astronaut had a blood clot in the in the right jugular vein. It was identified during duplex ultrasound of the neck, and it was just part of a regular study because with the significant fluid shift that astronauts have when they reach low Earth orbit or LEO, there's about 1 liter from each leg that comes up to the head and neck. So many astronauts get this initial swelling in their head, neck, and upper torso. Now, in some jugular veins, they remain distended. There's even reversal of flow in some jugular veins, and there are certain risk factors where you could form a deep venous thrombosis. This particular astronaut formed a blood clot. It was published in Lancet after the astronaut landed. And I will give you one hint. Look for patterns in medicine and in the human character, because it's patterns that will allow you to see things that many other people just kind of overlook. So the pattern I saw was, well, this astronaut had a blood clot, the extreme of the environments. I had been reading about single nucleotide polymorphisms and thinking about patients and how our patients have really swollen lower extremities. And what are some of the differentiators about why some patients heal and some patients don't? And so I actually called the physician that was taking care of this astronaut over in North Carolina. And I said, hey, by any chance, does this astronaut have a MTHFR abnormality, so methyl tetrahydrofolate reductase abnormality? Because a lot of our patients in the wound clinic that have a hard time healing their wounds do have these genetic abnormalities, so they can't produce endothelial nitric oxide. And if you can't do that, it messes up your immune system, your lymphatic function, arterial dilatation. It has a huge impact. And he happened to say, well, interesting that you ask. I tell you what, I'll set you up with the 2 people down in Houston that are working on this problem. And it was just, that's how I ended up in this position where now I get to play a small co-investigator part on a NASA Human Health grant and work with these fabulous people that I'm going to introduce to you shortly. But and now I'm looking at everything that they do in astronaut health, and I'm applying it right now to how I treat patients. It's how I treat lower extremities swelling, how I treat ulcerations. And so much of this is function and aimed at making sure the lymphatic system works to its highest degree. And interestingly enough, there's very little known about the lymphatic system in low Earth orbit. And I'm going to show you some images at the very end about a study we're just about to start down at in Fort Lauderdale at Nova Southeastern University on a space flight analog of 6-degree head tilt down, which causes significant fluid shifts, which is analogous to what astronauts experience. So with that, let me do a little screen share here. And you've got the recording going, correct? So we're all good there. We've got till, is it the top of the hour?
Yep.
So till about, okay, top of the hour. So at points, we're gonna go quick. Write down questions. We'll hit questions at the end. I'll leave some time at the very end. So we're gonna go through fluid shifts and weightlessness and talk about how these have some potential spin-offs into how we take care of patients. And we're gonna talk about some of this physiology and adaptability. Now, the word I'm gonna use is weightlessness and not microgravity. So microgravity and it makes you think, well, it's a small amount of gravity, but actually when the astronauts are up in low Earth orbit at about 262 miles, they're actually experiencing 0.9 or 90% of the normal gravity of what we experience. It's different because they're going so fast, they're falling around to Earth at 17,500 miles an hour. So it's almost like dropping down an elevator shaft. That's what's creating weightlessness, but they actually are still under the force of gravity by 90%. So saying microgravity, if you want to be a purist, it's actually weightlessness of space flight where the International Space Center is. It's going to be different if you're standing on the moon, different if you're standing on Mars, and different gravity effects based on the largest body that you're near in that gravity field. And then we're going to talk at the end a little bit about thermography. So I really enjoy watching all things space. Marcus House is one of my favorite guys. And, you know, down in Australia, you guys are well aware of what's going on with Gilmore Space. And they're creating these engines and they're launching. And I think it's really interesting because if you look at the entrail off the back of a rocket engine, it actually looks just like a lymphangion. So lymphatics, as you know, it's got a valve. It's got a little dilated area. This is the muscular component that contracts to move lymphatic fluid, and it's the same thing in these entrails of these rockets. So there's great biomimicry in these flames. So they're building these gorgeous rockets. It's going to have, it's going to be able to 3-stager that's going to get up to low Earth orbit, 109 satellites launched, and now up in the U.S. we have private with Axiom 1, which is going to use a Dragon coming up, I believe, within the next 2 months to launch the first private ever group of astronauts to the International Space Station. Now, the reason I bring this up is because for those of you that are looking for a career, aerospace medicine is going to be expanding. Because as more and more people start to go into low Earth orbit, it's going to require a lot more physicians and physician colleagues to take care of these people, and they're very specific set of environmental extremes they're exposed to. But it also impacts how we take care of people in Antarctica, how we take care of people that are living maybe on the seafloor, people that live up near the North Pole. So those environmental extremes have a lot of overlap with spaceflight. They just rolled out the new Artemis just on March 17th out to pad 39A, which is the historic pad where Apollo was launched. And this is a big rocket. Now, this first one's going to be unmanned. That's going to be a $2 billion launch. None of it's reusable like SpaceX. That's Dr. Bill Nelson that's presenting as it's rolling out past him. And there's going to be obviously many segments to this. And ultimately, this is going to carry and return the first astronauts from NASA back to the moon. So and the first woman to the surface of the moon as well. So you can see in the comparison of sizes, if Starship, which is down in Boca Chica now with Elon Musk in Texas, compared to the Saturn V, which was the original Apollo astronauts, compared to the SLS, it's a little bit smaller. And then, of course, to the space shuttle, and then the Falcon Heavy, which is Elon Musk large device. Now, it's interesting when you look at this classic NASA, it's called the worm logo. And worm because it looks like a bunch of worms that form the letters NASA. It was actually rolled out under the full moon of March 17th, which is actually the worm moon, and it happens once a year. And it's kind of in that time period when farmers are getting ready to put their fields back in. So again, this is the worm logo. And then this happened to be the full worm moon. So great coincidence. I'm sure they planned all of that. But when you look at the first physician in space, it was actually, or at least the first American physician was Dr. Kerwin. And his statement about exploration medicine is understanding and dealing with normal humans in abnormal environments. So a lot of interesting things happen to astronauts when they're in space for a long time. The fluid shift we talked about, you also get something called neocytolysis, where you actually you burst many of the red blood cells that you're producing. Your albumin levels tend to go down. There's changes in how you and how your calcium works. So you start to get thinner bones, less muscle mass. That's why they have to work out for 2 to 2.5 hours on a daily basis to maintain that, because ultimately you're going to come out of orbit, and when you land, you have to still be somewhat functional and without a prolonged recovery. So the training to get ready to go into low Earth orbit it's years typically. And what we're going to see, and the other reason you need physicians ready to take care of the humans are going to be going up now, is because it's going to be a much shorter period of time. You're going to have people that have been prepping for maybe 2 to 3 to 6 months, and they just can't get physiologically adapted and all the things you expect in that short of a period of time. Now, I passed on this website to Rowena in an email, but this is a free book each of you can get. I actually went to this website, I took it down to UPS, and I printed this whole thing in color. And this is by Scott Smith, who's a PhD. He's the manager for nutritional biochemistry. Sarah Zwart, who's a senior scientist for nutritional biochemistry. And this is the 2 people that I have the great fortune of playing a small part in the human health research program for NASA. And then Grace Douglas, who's well accomplished writer, as well as Martina here, who's over in Germany. So this book is really a tour de force. And again, take it down to one of your print it up in color, and there's so much information. This just came out late last year, incredibly up to date, rich with resources and all sorts of references to go deeper into. One of the things they talk about in here is how complex space food is to produce, to maintain, and actually just to get into orbit, because to get something to orbit is somewhere between $6,000 and $10,000 per pound. So if you think about a gallon of water, that's 8 pounds, and just imagine that that's like $50,000 to get 1 pound into low Earth orbit. So one of the things we're working on is how much food can we grow? Is it sustainable? Does it provide enough nutrients? Does it provide enough fiber? Does it help maintain our microbiome in our gut? And as you can see, looking at durability of nutrient stability is a big component, because especially if you're talking about going to Mars, which potentially is a 3-year round trip, how are you going to store food, or are you going to be able to generate enough food? And is it going to be stable enough, especially once you're outside of the Van Allen belt and you have an increased radiation exposure? How will that break down food? And then think about the amount of energy that it takes just to be in low Earth orbit. When you look at figure 8, it compares all the way from Apollo, Skylab, the shuttle, all the way up to current ISS expeditions. And it's interesting because all the astronauts use less energy, except when they're on their extravehicular activities, so their EVAs. Then their energy needs will go up, but otherwise, in a normal day, they're not using as much as energy as they would typically. Now, how do you weigh an astronaut in space when it's weightlessness? So you take advantage of the equation F equals mv. So force equals mass divided by velocity. If you change that to look for mass, solve for mass, it's force divided by velocity. So you can take advantage of that because you don't measure weight, you measure mass in space. And everything in NASA is an acronym. So it's using the SLAM. It means Space Linear Acceleration Mass Measurement Device. So with an astronaut on this, as quickly as they pull down, so that's acceleration or velocity, and then they can measure the force that the astronaut applies during that time, and then that gives them a very accurate measure of mass, because you've got to measure astronauts' mass throughout their entire time to know, are they nutritionally replete? Are they dehydrated? Are they healthy? Are they maintaining enough bone and muscle mass? And so you can see that they measure these through flight days and keep very close track on this. So this is an incredibly interesting device that they can use to do this. Now, water recycling, again, because it's so expensive to get into low Earth orbit, has to be in a closed loop preservation system. So that means that what you're urinating today is going to be tomorrow's water and tomorrow's coffee. Of course, it's going through these incredibly great filters to recycle all this. But ultimately, again, if you're going to go to Mars, you have to find a way to either make and produce water, either through chemical reactions, or you've got to be able to not lose any of it. And it's going to be the same with your microbiome. So potentially using things like stool to grow plants, because that has great nutrients in it. And all sorts of interesting things are going to be necessary in ways of thinking in ways that we just don't think of terrestrially. So one of my favorite chapters, chapter 10, and gets into the ocular issues of space flight associated neuroocular syndrome. And Scott and Sarah actually were the first ones to identify this 10 years ago when they saw that astronauts that had elevated homocysteine levels pre-flight were at the highest risk for developing these abnormal retinal thicknesses and changes in vision, and some of the other components that go along with spaceflight associated neuroocular syndrome, or SANS. Now, it's these single nucleotide polymorphisms where you have abnormalities in the genetics that was resulting in elevated homocysteine. Homocysteine in and of itself is a biomarker. It doesn't do damage itself. But if your homocysteine is up, it means that there's something going on in your circles where you produce, ultimately, how you break down these nutrients to make nitric oxide and other components that is resulting in abnormality. So in environmental extremes where you have swelling, you don't produce as much endothelial nitric oxide. It's the exact same thing that's happening in our patients in our wound clinic, where they have significant swelling in their legs. And if they have a genetic abnormality like MTHFR, they're not producing normal amounts of endothelial nitric oxide. Therefore, their veins, arteries, lymphatics, and immune system don't work normal. And this is really where my first big connection was in this paper that they had published in the Journal of Ophthalmology. Now, this is Mark Vande Hei. He's actually deorbiting March 30th. He's coming down in a Soyuz capsule into Kazakhstan with two cosmonaut colleagues. And he'll have set the American record at 355 days when he deorbits. He's actually a native of Minneapolis, Minnesota, where I'm at right now. He went to high school where my kids went to high school. We don't know him, but good for him. He's done a fabulous job. But it's amazing the oxidative stress and the immune changes that astronauts experience. So there's changes in their skin microbiome, changes in gut microbiome. Many astronauts will have reactivation of herpes virus simplex because their immune surveillance isn't working as well. And some astronauts will age physiologically and by biomarkers multiple years for spending 6 months up on the space station. Now, most of that reverts when they land, but it is a significantly stressful environment for astronauts. Now, there's two chapters in medicine that are becoming very important for overall bodily health as well as just simply organ health. One of them is the microvascular endothelial glycocalyx, which we're going to hit in depth. And then the other one is just lymphatics. Lymphatics still remains a well under-taught component within medicine. It has a disproportionately large impact on how our body works. Now, it's interesting because there's 200 trillion with a T, chemical reactions in the body every single second. And that's because every cell is doing something to maintain homeostasis at every second of the day. And so when you have disruptions of homeostasis, that's where you start to get organ breakdown, cell death, and dysfunction. So the microcirculation is one of my favorite areas to talk about. It's 50 to 60,000 miles of length if you look all the way down to the 5 micron level. Now, 5 micron level is 1/3 the size of your hair. Most hair is about 17 to 20 microns in size. And so this microcirculation is actually the vast majority of our body. It's not the aorta. It's not the named tibial vessels, the popliteal vessel. And the microcirculation is where all oxygen and nutrient delivery occurs. So this is really the most important component of our vascular system in terms of cellular viability. So endothelial nitric oxide synthetase is the enzyme that allows us ultimately to produce endothelial nitric oxide that has all these significant positive benefits. Now, when you have chronic inflammation, it increases your cardiovascular risk for things like heart attacks, strokes, and significant arterial disease. So the things that cause this inflammatory component throughout our body are things that we well associate with ultimately developing arterial disease or significant end organ disease. So it's diabetes, being on dialysis, having either venous hypertension or arterial hypertension, having high cholesterol, tobacco use, the severity of elevated body mass index, so, and autoimmune diseases. All these things cause significant inflammation throughout the entire body that then leads to ultimately cell death. So when you look at this in a close-up nature, each one of those red blood cells is about 3 to 5 microns. And this is where significant, where all the delivery of oxygen and nutrients occurs. So when you have damage at the microcirculatory level, this is where you get fluid leakage. And as you get fluid leakage, it does even more damage. So it's a very vicious negative cycle. Again, we see it in patients with lower extremity lymphedema, patients with lower extremity venous ulcerations. Now, the analogy for the glycocalyx is to think about it from a functional ontology component. It's like a computer. Computers all have 3 things: hardware, software, and a power source. The endothelial glycocalyx, it's got hardware because within its components, it's basically all sugars. So it's things like these glycoproteins, proteoglycans, glycosaminoglycans, and then there's the micronutrients, so B12, B6, all these other components that make the endothelial glycocalyx function. Now, the software is the genetic component, and then the power source is simply the flow of the blood flow through these small blood vessels. That's called mechanical transduction. So as the blood flow goes through, it makes these little hairs of the glycocalyx move that we're going to show here. So this is and look at the scale, that's 1 micron. So this vessel is about 5 microns across, and all these little hairs are the sugars that make up the glycocalyx. Again, this coats the entirety of the 60 to 70,000 miles of arteries, veins, and lymphatics throughout your entire body. And this is what makes everything function correctly. Think of the Great Barrier Reef. The places where the Great Barrier Reef are the healthiest is where there's good, clean water motion, and there's a lot of population of fish and other organisms that live there. It's colorful, it's vibrant. And then when you get areas of stasis where the water doesn't move, there's too much salt, there's no more fish, it all results in bleaching, and you have a dead reef. So it's the same thing within blood vessels. When you have smoking, high blood sugar, high cholesterol, high pressure, either in the venous or the arterial system, you lose or shed this glycocalyx. And when you do that, the blood vessel no longer functions, especially with production of endothelial nitric oxide. So the mnemonic for the glycocalyx is EPIC, E-P-I-C. So E is endothelial cell function, so the ability to produce things like cytokines and nitric oxide. The P part is permeability. It acts much like Gore-Tex. Usually when fluid comes out, it's not going to come back in if it's intact. The I stands for inflammation. So it quenches inflammation, so you don't have that component of lack of homeostasis, and it can prevent, especially one of the big things that could cause inflammation is white blood cells attaching, because when they attach, they think they're supposed to spill out everything on the inside, which of course does a lot of damage. And then C is the coagulation component, so it prevents inappropriate coagulopathies. One of the interesting things is in COVID, it's well recognized that you shed your glycocalyx, which makes sense because now you've got inflammation. Now you've got the permeability, especially in the lungs where the glycocalyx is the thinnest. It's thickest in the brain. And then you end up with these microthrombi events, so the coagulation you've lost. And then you've also lost in bad cases of COVID, the ability to produce cytokines. So this is a 2021 paper that demonstrates down again to the cellular level, when you have shear stress, again, that's the movement and that's the mechanical transduction that makes the glycocalyx wave. When it waves, it couples the enzyme endothelial nitric oxide synthetase to produce more nitric oxide, which actually has an impact on target genes within the nucleus. So you can see when the glycocalyx is intact, it decreases reactive oxygen species. Yet when you have shedding of the glycocalyx, now you've got increased amounts of reactive oxygen species, so you have more inflammation. You can't produce nitric oxide because you've uncoupled your endothelial nitric oxide synthetase. So it's a very vicious cycle once you get these, once you get this kicked up. Now it's a very dynamic and a three-dimensional layer. All these pictures look two-dimensional, but there's many things going on all at the same time. The big takeaway again is production of nitric oxide, which is critical to organ function. So again, just pointing out EPIC and how important it is that when you shed it like this, you can get platelets to stick, white blood cells to stick, and you lose your ability to manage all the reactive oxygen species that can result in significant inflammation. Again, some of the important things that can result in shedding of the glycocalyx are smoking, high blood sugar, high cholesterol, trauma, sepsis, and those are some of the most important things. So if you think about, if you've had a chance to spend time in the intensive care units yet and you've seen somebody that's septic, they all look very swollen. And that swelling is because they're putting all the fluid that you give them into the third space. And typically their systemic vascular resistance is very low, and it's hard to get enough volume in to keep their blood pressure up. Once they get over the traumatic event, then they tend to mobilize that fluid and they have a diuresis, or they lose all that fluid. Well, all that fluid was collected by the lymphatic system that you then urinate out. So you can rebuild your glycocalyx typically in about 7 days once it's been shed, once the source of shedding is gone. So this again is, especially in diabetics where we know they're shedding their, or thinning their glycocalyx or shedding it, maintenance of daily blood sugars is incredibly important, because ultimately long-term damage to the glycocalyx is resulting in things like retinopathy, neuropathy, loss of microvasculature, which then ultimately results in things like tissue loss, toe loss, amputation. Again, the glycocalyx is even within lymphatic vessels to help it lymphangion contractility. And so there isn't a part of the body that isn't ultimately impacted by the glycocalyx. Where I see a lot of the patients in our wound clinic and in surgery that I deal with is the patients that have venous hypertension where the glycocalyx is being shed. There is one specific medication that's available only in Europe called sulodexide. It's a fast-acting form of heparin sulfate and dermatan sulfate. This has been shown to restore the glycocalyx, not available in the United States. This is just a photo again showing there are many papers published on single nucleotide polymorphism, abnormalities associated with venous hypertension and lower extremity leg healing. We went back ultimately and looked at our own patient population, 88 patients, and found that within our patient population with venous leg ulcers, 52% of our patient population had an abnormality, had an abnormal genetics. And most published reports will show somewhere around 40%, so ours was higher. The normal population is about 20% of abnormalities. So as you would expect within our wound clinic, much higher, and these are the people that are having a hard time healing. We put everybody in our wound clinic automatically on B12, B6, folate. We add in micronized purified flavonoid fractions for everybody. And there's about 5,000–6,000 flavonoids in the world. This specific one is hesperidin diosmin, which comes from the rinds of citrus fruit. And we use this very liberally on everybody. Again, this has been in Europe for probably 50 years. I think there's at least now 10 or 13 or 14 randomized controlled trials utilizing this. Relatively new to the United States in the past 6 years, but we've become early adopters on utilization. We use high dose vitamin C, high dose vitamin D3. It's amazing the number of people that are vitamin D deficient. We're right on the 45th parallel, so halfway between the equator and the North Pole. We have a lot of vitamin D deficiency here. And if patients have been on steroids, we give them about 2 weeks worth of vitamin A to make up for the impact on production of collagen. We have everybody stop drinking sodas, especially if it's a phosphorus-rich soda. We try to get everybody to stop using tobacco. We talk about a Mediterranean-style diet, which is rich again in flavonoids and fiber. One of the medications that really causes a lot of lower extremity edema in our patient population is Norvasc or amlodipine. So if you see that medication as a calcium channel blocker, it's one you want to stop on your patients because it's very difficult to heal these lower extremity ulcerations if they're on that medication. And diuretics, specifically just to treat lymphedema, do not work unless patients have a history of congestive heart failure, kidney disease, liver dysfunction, or pulmonary hypertension. So if a patient simply put on diuretics to try to lower lower extremity edema, it will not work. So here's typical edema, right? So you got to touch the patient, and when you push right over the tibial margin, a dent like this demonstrates that there's significant edema, and by definition, if there's edema like this, we know the lymphatic vessels are not working. So this is lymphedema. Now, that it's a matter of, is this lymphedema reversible or is it non-reversible? So some people will have a genetic component where it's non-reversible, you're treating it for good. This could be potentially somebody that just had acute congestive heart failure, you get the cardiac status taken care of, and then this will all go away eventually. So understanding the clinical symptoms will help you understand, is this permanent lymphedema or temporary? Now, one of the analogies I use for lymphedema is it's kind of like a flooded farm field. And if you looked at a field like this, you certainly would not spend money putting phosphorus, magnesium, corn seed, etc., wheat into this field because you know it won't grow. Yet we have many people who are treating legs that have severe swelling, and they're putting on these very expensive tissue products to try to get the wounds to heal. It's much, again, until you get the field drain, until you get the lymphedema taken care of, your products aren't going to work efficiently. So we're very focused on getting rid of lymphedema in the interstitial fluid. So here's a gentleman with primary lymphedema tarda. He's had swollen legs for 20 plus years. That's his sister in the background. And we are just struggling with this guy. I think I've known this guy now for 2 years. We finally got his right leg healed. We're still struggling on his left leg. First thing in a leg like this is check arterial status. So duplex ultrasound, ankle brachiolendices, make sure the arterial blood flow is good, because if you don't have good arterial blood flow, it's hard to do good compression to treat the lymphedema, to take out the interstitial edema, to help maximize blood flow to the wounds and to get them to heal. But if you just stand in the room with this guy, you can actually see these wounds fill up with fluid. So lymphorrhea, you literally can just watch this fluid accumulate in these wounds. Very difficult and challenging situations. Now, this is one clinical situation where I debrided this gentleman in the operating room. We got rid of his lymphedema. I ended up doing a bunch of skin grafting, and here he was about 3 months later. So we can get good restoration and regeneration of lymphatic function that then results in skin health return. And again, we use all these micronutrients in all these folks and are very focused on getting lymphatics recovered. And again, as you just look at these photos, you can see all of these swollen legs. And so now when I see patients, it's remarkable as I look at other people discuss cases, as I see case reports, how often people aren't treating the underlying lymphatic component of this. So my advice is learn everything you can about the lymphatics, treat the lymphatics, and oftentimes that'll help decrease recurrent ulcerations, will help the wound to heal quicker, and will help the immune system as well as help the entire body to get that taken care of. So what we deal with in the clinic is kind of just cell to cell to cell, we're trying to get to be healthy. And we know that if we improve leg health and get lower extremities to be healthier, people are less likely to have things like heart attacks, strokes, etc., because they're more functional. They can walk better, they tend to eat better, they're able to moderate their BMI. So getting wounds healed does help systemic health quite a bit. One of the interesting things about the lower extremities is that when you look at the lymphatic system, it's actually all subatmospheric. So the pressure within the lymphatic vessels is actually, because it's below subatmospheric, if you started to get functioning in the thighs, it'll actually suck up the fluid out of the calves, much like sucking on a straw. And this is called Guyton's principle. He first described this in 1974. And then this group of physicians, so Michael Davis, who's down at University of Missouri, Scott Zawisza, who's at University of Missouri, David Zawisza, his father, is now down at Texas A&M. So this group of physicians or researchers went and proved that Guyton's principle actually is very important. I think this actually applies to part of the reason why astronauts are getting significant head and neck swelling. Because if your legs are already primed to move fluid back up to your heart through the thoracic duct, that means when you're laying on the launching pad, your legs are typically up above, your legs are elevated, and then you're typically there for about 3 to 4 hours before launch. So you've already started fluid shifts. And then once you hit low Earth orbit, that system's already pumping very hard, and you get this dramatic shift within the first 24 hours. Now, in this paper, Scott Smith, he helped write this in 1996. So this paper's been out almost 30 years about how to the regulation of body fluid compartments during short-term spaceflight. Again, this showed that within 6 to 10 hours of reaching orbit, there's this big 1 liter shift is a lot of volume. And then they also see extracellular fluid volume decreases, plasma volume overall ultimately decreases. So you actually have less fluid inside the blood vessels, but your total body system remains the same. That's because there's increased permeability of the capillary membranes that's resulting in plasma volume leaking out. This is also part of the reason why when people come back from orbit, they experience something called post-flight orthostatic hypotension, or they get lightheaded and difficult time walking when they land. So they have these protocols where they're drinking a lot of salt-rich fluids before they deorbit to try to compensate for this. So this glycocalyx is a significant part of something called the revised Starling curve. So the old classic Starling curve that they will still be teaching in medical school is that when fluid leaves the vasculature, about 80% comes back into the vasculature and very little goes into the lymphatics. So that's the classic Starling curve. He developed that in 1896 when he was in Britain. The revised Starling curve or revised Starling function would tell you that actually most of that fluid never goes back into the vessels. And that's because of the glycocalyx. So that means that almost 100% of that fluid has to go into the lymphatic vessels. And this is part of the reason why the lymphatic vessels now have had such a significant renaissance in terms of research and in terms of treatment, because now we know that the lymphatics are responsible for remobilizing all this interstitial fluid. Again, this is just another picture of the glycocalyx showing some of those significant components of the hair-like with heparan sulfate, albumin, chondroitin sulfate, hyaluronic acid. It's kind of like a layer on a lawn. And we know that when your lawn is healthy, it maintains the dirt in good condition. We know that it's very protective of the soil. But when we lose it, so if you lose albumin, which again, astronauts' albumins tend to be lower in flight over the course of time. And we know ultimately also with diabetics, they tend to spill albumin. They have lower albumins. People with sepsis, people that are chronically ill, they tend to have a lower albumin. All fits because we know their glycocalyx tends not to be as thick and tends to be not as functional. Here's actually a magnified view of the brain. So the blood-brain barrier, which a significant part of the blood-brain barrier is the glycocalyx. And they use a special stain called lanthanum to preserve the glycocalyx. So the top images show without lanthanum. This is where all the glycocalyx is wiped away. And then the lower pictures show with lanthanum where the glycocalyx has been preserved. It almost looks like that lint that you would pull out of your dryer after doing your laundry. But that functional layer you see is incredibly important for maintaining a homeostasis within all the organs. So when you lose your glycocalyx or parts of it, you end up like this. And part of the blood vessels will dry and become non-functional, just like parts of your lawn. And then ultimately, again, you can end up with blood clots. And this is where I made the connection. And so there's been very little work on the glycocalyx in terms of astronauts. I think there's a whole opportunity there to do a lot of really interesting things. But this particular astronaut, again, it was published in the New England Journal of Medicine about, it's a very interesting article. And it was in conjunction with when they were looking at the assessment of jugular vein blood flow. And this again is where they found that jugular veins get big. There can be reversal of flow. And it was during this study where they happened to find this one astronaut that had the asymptomatic deep venous thrombosis vessel. They put the astronaut right away on Lovenox. It happened to be in the space station's medical cabinet during a resupply mission. About 45 days later, I think they flew up, it was Eliquis, and the astronaut ended up on Eliquis. They stopped the Eliquis, I think about 3 or 4 days before getting into the Soyuz capsule. And once it landed in Kazakhstan, they did an ultrasound right away, and the blood vessel was actually fairly wide open at that point. They went through a genetic evaluation. There was no underlying genetic cause. So the whole thing is still being evaluated. But I think the big question is, how do you prevent this from happening again? Because if you're on the moon, you're 3 days away from getting home. If this happens, 3 months into a trip to Mars, there's got to be a way to treat this. And ideally, the best way always is through prevention. And so it's doing more research, because you don't want this to happen. When you totally lose the glycocalyx, it's like the desert, right? Everything just kind of starts to fall apart. And that I am so sorry, my pager's gone off. We'll get it turned off. So ultimately, blood-brain barrier is critical part, again, with the glycocalyx. So if you want good brain functionality, you got to maintain your glycocalyx. One of the interesting things they're finding about astronauts is, even after coming back for 6 months, they're finding that astronauts still have significant increase of volume in the brain's white blood or white matter. And they get some degree of ventricular expansion. And so total fluid within the brain might be about the same. However, the amount that's inside of cells is disproportionately abnormal. So there's still a lot of discussion going on about what exactly is causing this. It'd be interesting to find out what is the blood-brain barrier component and what's the glycocalyx component in astronauts' brain, and is that resulting in some degree of hyperpermeability that's resulting in changes? Because if there's distension in the jugular veins, that may be transmitted all the way up into the sinus veins of the brain, and that's venous hypertension, just like I deal with in my patients in the wound clinic. The other thing I think we have to start understanding is, how does the G lymphatic, or the sweeping lymphatic component of the brain that cleans all the toxins, how does that impact astronaut brain health? Because the G lymphatic system really functions best when you lay flat at night for about 6 to 8 hours. That's when it sweeps through the brain to take out the beta amyloid 42 and other toxic metabolism. The problem with astronauts is they never truly sleep supine. They're always, basically, it's like they're head up. So their G lymphatic system likely doesn't function as well. And one cosmonaut study that was published about 6 months ago actually showed that when the cosmonauts deorbited, there was a significant dumping of beta amyloid 42, which means all of a sudden the G lymphatic system was kicking in. It was sweeping all of that metabolite out of their brains. So a lot more details have to be figured out on that, but I think the G lymphatic system of the brain is also going to help. And given that they now know that the G lymphatic system also has an ocular component, how do you tie this all in with spaceflight associated neuroocular syndrome? So there's a lot of really complex moving parts to ultimately figure out, why do the astronauts develop this? Again, we know genetics is a part of it. Genetics for precision care of the patient is going to be very important to figure out. And I think that in your careers, just like right now, you can sweep your mouth and do a 21andMe and figure out your heritage. I think we're going to be able to do this for certain medical conditions, and figuring out this genetic component to how we treat patients is going to really improve how we ultimately care for patients. Now, they've already shown within biosatellites that nitric oxide production is decreased. And so these studies have already shown that there's an uncoupling of endothelial nitric oxide synthetase. There's decreased nitric oxide production in these cells. And in this one particular study, we showed that it was reduced by 26% when it was in true space weightlessness for 3 days in this biosatellite. And this ultimately does have an impact on how we potentially can help treat our diabetic patients, because we know that diabetic patients end up having thinning of the retinal glycocalyx. And then if we can figure out how to improve the glycocalyx by certain medications, we should be able to help slow down retinopathy. But this is also what's happening in the patient, in the astronauts with spaceflight-associated neuroocular syndrome. This was published in 2021, early 2021. This shows thinning of those retinal blood vessels and loss of the architecture. And this was in one specific astronaut that had been up on the station for 6 months. And their small vessels all were much less in terms of density in this particular astronaut. So a lot more work again has to be done on this. But again, it comes back to, is there a significant change in cytokine production? Is there a significant change in the glycocalyx component? So I just want to hit thermography very quickly so that you guys can see what we're going to be starting here. As I've got about 5 more minutes here, we'll do questions. But frontward looking infrared cameras give us the ability to look at temperature within the skin and within the dermis and the epidermis. So we know that as more blood flow goes into the leg, so when you stand up, if you've got bad veins that have leaky valves, and it goes backwards, you're going to see an increased skin temperature, which shows up as kind of a white hot spot. And this is actually a very sensitive form of thermography from a company called ThermPix. You can literally see in this patient's leg the thermal pattern of the veins. You certainly can't see with your eye. You could see with an ultrasound. It's going to take much longer, and that one image can be taken basically just by snapping a picture. So I think thermography is going to be a great way to start to look. Now it's also now there's published reports of somebody that had breast cancer and ended up with lymphedema of the arm. This was a study from Poland. And then looking even at, this was a particular image, had to do with looking at head and neck swelling. This is exactly what we're going to be using different types of thermography for. And they've even now done it over in Africa, looking at filarial lymphedema to be able to evaluate patients and develop baseline imaging. So these were all patients, obviously, that got bitten by a mosquito that had the filarial component and ended up with filarial-related lymphedema. So infrared's already been used on the shuttle. It was actually used after the Columbia incident in 2003 to look at the leading edge to make sure that the edge was intact and that it wasn't damaged. So you can see an astronaut on an EVA working on some of that component. And so thermography's already been used, but much, much bigger cameras and not for human exploration yet. Now, another interesting point to look at would be determining astronaut core body temperature, because we know that all astronauts' core body temperatures actually elevate in space. Now, this means that this usually is related to increased inflammation. So could this also help keep better track of astronaut health? So and these are the type of images that we're going to use. We're going to use something by Wound Vision, something by ThermPix, and then near infrared spectroscopy through Kent imaging. And then we have a specific from Delphin. It's a tonometer that we can actually measure the amount of fluid in the skin just by light pressure. So none of this has dyes, none of it has a needle. It's all completely non-invasive, and it's going to allow us to look at volunteers in a 6-degree head down tilt and to look non-invasively with 3 different imaging modalities to determine the sensitivity, specificity, and then that'll help us determine the next study to do to look at countermeasure development, which could be as simple as manual lymphatic drainage. We could look at pharmacologic agents like micronized purified flavonoid fractions. But once we have a good baseline, now we can look at how do we develop countermeasures that potentially could be trialed in actual space. So one of the most important things for you guys as researchers is nobody's going to let you do stuff in space until you've absolutely proven it beyond a shadow of a doubt on the ground. So it takes a ton of work. And one of the most important things is collaboration. So work with as many people as you can, which means you got to be nice and kind. And, for a surgeon like me, it means checking my ego at the door, because nobody wants to work with an egotistical surgeon. So, we all get along very well. We have people from various different places that are working on this grant, and it's been a lot of fun to put this together. So ultimately, I think as we look at the physiology and understand the medicine that's going on in low Earth orbit and on the space station, this will dramatically change how we treat patients, not just in our wound clinics, but it might change how you treat people that are exploring, say, Mount Everest, it might change how we're going to treat the people that are exploring the seafloor. So I think all the way from all these different gravity and different environmental extremes can certainly benefit from doing all of this. And ultimately, I'd love to see Rowena and I contributing to a chapter ultimately to these handbooks, the Principles of Clinical Medicine for Spaceflight. It doesn't have any chapter at all yet about lymphatics. And the Handbook of Venous and Lymphatic Disorders, it has nothing about the glycocalyx yet. So we need young, smart people like you to start to write these new chapters as you do research. And I'm going to end it with that slide. So we got a couple minutes here for questions and answers.
Thank you so much, Mark. That was absolutely wonderful and inspirational overview of so many cutting edge topics in both terrestrial and spaceflight medicine. So we do have a few minutes for questions. So if any of you would like to ask a question, please go ahead. No need to put it in the chat, just unmute and ask.
Do you anticipate any potential problems with using, what is it called, the thermography in space?
Well, they've already used it to look specifically at shuttle space tiles. They haven't used it that we're aware of to image actual humans. So because it's non-invasive, because it doesn't involve any dye, it's literally like taking an iPhone and taking pictures. So you could, the minute you hit, 62 miles or 100 kilometers is considered the border between space and Earth, or being in Earth's environment. The minute you hit that 62 miles, things start to change. So you could use something like this to start taking pictures every 15 minutes right away, ideally. And as there's more opportunities that don't involve NASA, don't involve the cosmonauts, I think there's going to be some opportunities to start doing some of these things right away, especially in that first 24 hours. So I really don't anticipate any challenges, certainly from causing harm, because it's totally non-invasive and requires no dye. And that's the beauty of it, is that it can be used in that fashion, and the pictures can be taken by anybody. I think the training would be pretty easy to train anybody how to do that. Look, if they can train me how to do thermography, I think they can train just about anybody to do it. That's a very good question. Thank you, Marta.
Thank you, and thanks for the presentation. It was really cool.
Oh my gosh, my privilege.
Any other questions?
Yeah, I had a question regarding the revised Starling curve. Does that revised Starling curve only come in under circumstances, or are we just discovering that's just more accurate than the original Starling curve?
So that's, Edmund, a really good question. The Starling curve, 1896, when Ernst Starling did it, Guy's laboratory down in the bowels of the hospital with his dogs. And it was about the early 1990s where they started to, when they were really doing definitive science with current accurate data and techniques, they said, you know what, something's not right here. We're just not seeing what we know to understand to be the Starling function in this microvasculature. And it was hard to see the glycocalyx at first because most staining eliminated it. It was just gone until they figured out how to preserve it. And then even once you preserved it, how do you look at it actually function? Because it's such a, it's very sensitive layer. So once they started to understand what it was, what its function was, how you could preserve it, then how you could test it. And it was about 1997 where the first Sentinel paper by C.C. Michael, when it was the 100th anniversary of Ernst Starling's paper, where he said, you know what, with all due respect to Dr. Starling, it's not true anymore. And I think if Dr. Starling were alive today, he'd say, I am so glad that you all figured it out. I did the best I could in 1896, but in 2022, we got to do something different. Now, again, I've got a son who's a urology resident, a daughter-in-law who's a medical student, a son who's a medical student. They're still teaching the classic Starling curve because that's how the test questions are written. So all my kids know about the glycocalyx, yet if you answer the glycocalyx on today's test, you'll get the test answer wrong because they haven't changed the test yet. So until we change the test, education is going to suffer, even though the revised Starling curve, I always put 2014 when that paper by Peter Mortimer and out of the UK and Stanley Roxon out of Stanford wrote that definitive paper in 2014. It's been now 8 years. And I think it's time we start changing the test so that smart guys like you, Edmund, can answer the question correctly. And I think that's what's then going to advance the science. So we actually have Dr. Roxon speaking for us down at what's called the Space Forum at the American Venous Lymphatic Society in New Orleans in October. And Stanley's been writing about this educational deficit for a long time. But it has changed everything. It also changes how we treat people. It's dramatically changed how we treat people. We just need now more countermeasures to restore the glycocalyx, because I think that's what's going to lead to more functional health, especially for our diabetic patients and for our patients with arterial hypertension, venous hypertension, etc.
All right, thank you very much for that. And I also really enjoyed the presentation.
Thank you. Man, I gave you a long answer, didn't I?
It's good though. It makes sense.
Typical surgeons, they just talk. Oh my gosh.
Well, it's really important to know about these things, and I'm really glad that you all had the opportunity to hear about that today, and that was one of the reasons why I was really keen to try to get Mike to come along and talk to us. So I know some of you have to go to other commitments now. So on behalf of everyone, I'd like to say again, thank you so much for coming along today and giving such a wonderful and inspirational presentation. And if we can all show our appreciation, that would be wonderful.
And I want to say one more comment. I mean, I hope you guys all know how privileged you are to have Rowena as a teacher. I mean, she's like this internationally recognized person that everybody loves. And when we did this Australian biology conference, everybody loved what she was saying. And she was one of 3 people in the world that helped lead this thing. One of 3. So I will just tell you, it's such an honor. And you guys are super privileged to get to hang out with her routinely. I would love to be in Australia and hang out with her all the time. So thank you again, Rowena. I really appreciate the opportunity to do this today.
Thank you. It's been really lovely to spend time with you today.
All right, y'all have a great day. Enjoy, let's see, it's Wednesday for you, right?
Yeah.
All right, enjoy your Wednesday.
Thank you. Take care.
All right.
Thank you.
Oh, my pleasure. Take care.
Hey, Matt, can I just ask you one last question?
Yeah,
Not sure if you can
absolutely.
hear me now.
I can.
Having some issues. Considering you look so closely at wound healing, is there any specific things that get in the way of wound healing in space? Like, has there been any evidence that shows wound healing in space apart from obviously you're going to get different things with the vasculature, like especially that cephalic shift. Obviously that would have a role to play, but is there anything really specific to space? And
So there is. So there's a really good paper right here. It's Microgravity and the Implications for Wound Healing. It was written in 2008. And so if you, I'll spell out the author's last name, because if you go to PubMed, you can get the paper. And then usually what I do in PubMed is I look what other papers have referenced it. So I can then work from 2008 to all the current papers that are referencing this one paper, because I found this paper to be incredibly beneficial. So there is more data coming in. I think the endovasculature, and you're right, I think the head and neck swelling may make it more difficult to heal head and neck wounds. But even how do you heal a fracture, a bone fracture? Because to really heal a fracture, it has to be set, and the fractures heal the best when you walk on them. That stress helps bone recovery. Now, I think electrical stimulation might be beneficial in space to help reset the electrical grid, because we know that's disrupted in wounds. And that certainly has been utilized to help heal bones as well, electrical stim. So e-stim may become a thing. So again, the title of this paper is Microgravity and the Implications for Wound Healing. The first author is Farahni. And I've got another one. They've done some animal studies and some things like that. There was one other study the title's called Mechanochemical Aspects of Skin Wound Healing and Microgravity. And that was published in 2019. First author is SWAIN. And that'll get you a good start on looking at it. But they've looked at some gels and some other things to help with healing. It's going to have to be radiostable. It's going to have to be lightweight. It's going to have to be durable. People are going to have to be able to use it easily. So developing the next segments of wound care and the products that will help accelerate healing in that environment, I think are going to be very important. And we need smart people like you to figure it out.